Good afternoon. I'll be presenting on the next generation LASIK surgery based on Bowman's topography. I have no financial interests. So these are the various epithelial maps, and these are the corresponding topographies. All of them have a refractive error of approximately -3 with -1 at 180. So if we operated on these patients, would they all have the same outcome? Let's take, for example, this patient with normal K1s and K2, and when we operated on this patient, they had an optimal outcome. A similar looking topography with similar Ks had a suboptimal outcome. So why was this the case? We had to literally dig deeper. It was because the epithelium was masking a steeper Bowman's. So from literature, we know that the epithelium can actually act as a great confounder on what is lying underneath. So the current available devices do not dissociate the epithelium from the Bowman's. Herein comes the need for Bowman's topography. So what is this Bowman's topography and why is it important? So let's start with how we obtain it. From the AIOS and with the help of edge detection software, we get the anterior surface as well as the Bowman's surface. And then we get curvature data of the anterior epithelium interface and the epithelium Bowman's interface. And then with ray tracing technology and Zernike's analysis, we calculate the aberrations. So when we are undergoing refractive surgery, if the topography and the Bowman's curvature match with a good epithelium, we generally get favorable outcomes. However, if the topography and the Bowman's don't match and there is epithelial thickness, the outcomes can be unfavorable or something we're not imagining. So is this the first time this has been done? No. Gatinel et al. Has done Bowman's topography. However, in their study, they had to remove the epithelium and then during surgery go take the patient and get the Bowman's topography. So it was intraoperative and invasive. So the aim of our surgery was to assess changes in visual acuity, contrast sensitivity, and ocular aberrations between LASIK and Bowman's assisted in situ keratomileusis or basic eyes. As I mentioned, the methodology, we took the anterior OCT scans, we got the anterior surface and the Bowman's surface, and the tangential and the actual curvature data, and then with the help of ray tracing and Zernike's analysis, we calculated the aberrations. 130 eyes of 65 patients were included, which had stable refraction and a residual stromal bed of more than 250 microns who were willing to undergo the study. And we excluded any patients with previous ocular surgery or scars or who were uncooperative. And then one eye, conventional LASIK was done, and the other eye, LASIK following Bowman's topography or basic was done. The follow-up was done at 1 week, 1 month, 3 months, 6 months, during which the visual acuity, aberrometric outcomes, and the contrast sensitivity for these patients was seen. So preoperative characteristics between the both eyes was the same. In visual outcomes, both LASIK and basic group, they increased by 2 lines, but they were not statistically similar between the 2 groups. Even contrast sensitivity improved in both the groups, but they were similar between the 2 eyes. And aberrations were comparable between the LASIK and the basic eyes. However, the spherical aberrations was more increased in the basic eyes. So both the LASIK and basic had excellent outcomes, but there was a greater change in the ocular assay in the basic eyes as compared to the LASIK eyes, and this needed to be evaluated further because with aberrations, vision and contrast unchanged, a small change in K value can alter the assay drastically. And we know that lower ocular assay leads to better intermediate and near vision by improving the depth of focus. So when a laser machine fires the lasers on a topography assuming K, X and Y, then there is peripheral loss of energy. However, if we trick the machine into thinking that the cornea is steeper than it actually is, so say X plus 2 and Y plus 1.5, then the rays are equidistant and there is no peripheral loss of energy. So keeping this in mind, we operated on a 43-year-old male and we did one eye basic surgery, which was 2 diopters steeper, and the other eye conventional LASIK. So post-operatively, we saw that the right eye, which basic was done, was 6.6 N6, and the left eye, which had normal LASIK done, was 6.6 N10. So this is basically a proof of concept that Bowman's topography-based correction was safe in epithelial and topographically healthy corneas. It's an ongoing trial to do this in pre-presbyopic age group, where altering the curvature can play a significant role in changing the spherical aberrations and the depth of focus. So we don't need Fresbiond or any other lasers to achieve this. And in irregular epithelial maps, the Bowmans may be different than the topographies, as in cases of long-term contact lens wearers. So we should keep this in mind. And in keratoconic eyes, it can be useful in topo-guided treatments too. Thank you.
Thank you, doctor. Thank you for your good presentation. Now we will move on to another